we go. This public deliberation that we'll be presenting some preliminary results on was held just 2 months ago in April of this year. The title for the deliberation was Funding Fair and Sustainable Cancer Programs and Services in British Columbia. It was held over 2 non-consecutive weekends, April 13, 14, and April 26, 27 here in Vancouver. The deliberation was part of a larger CIHR FISI grant, and the co-PIs on that grant are Stuart Peacock and Mike Burgess. We had 26 participants at the deliberation. They were members of the BC general public. Participants deliberated on 5 questions, including one on survivorship programs, and we'll present some preliminary findings on that. And as mentioned, the transcription is still underway. So again, the caveat is that these are preliminary findings. So what is public engagement? My apologies if many of you already know about public engagement or are well-versed in this field. There's considerable nomenclature around this idea of public engagement. Synonyms include deliberative democracy, deliberative politics, participatory governance, and so forth. Perhaps the easiest way to think about public engagement methods is along a continuum, moving from communication through consultation to participation. So if you have a policy initiative to be implemented, you might want to communicate that information to the public. And that would be one-way communication or one-way flow of information. That would be through a media announcement, a hotline, drop-in centers, and so forth. Or if you want some feedback from the public, you might want to consult them on the policy initiative to be implemented. And so you might do a survey, do opinion polls, or focus groups. And the most interactive and most, engaged of the 3 types of public engagement methods is a participatory one. And that is where you're seeking advice from the public on the policy initiative. And advice is usually in the form of recommendations and finding public values about the policy initiative. So, of course, our work is right in that public engagement or the participatory aspect of public engagement methods. So then what is deliberative public engagement? Deliberative public engagement is a specific form of civic engagement. It seeks values-based collective responses to challenging social problems. It's important to note that not all policy initiatives are good candidates for public engagement. I'll talk a little bit about that a little bit later. Participants at a deliberative public engagement are engaged in a process of learning and exchanging views over time. So the temporal component of deliberative engagement is very important. Our events are over 4 days. Some of them are over 1 day. Some are 2-day models and so forth. And that's very different from a focus group where you spend maybe an hour or 2 with a much smaller cohort of individuals. The participants at a deliberative public engagement are informed. We want to help provide some information to them. At the event, we provide participants with a range of perspectives on the topic. At our event, we had, in person, we had 2 patients to talk about their experiences with cancer. We also had Malcolm Moore, who at that time was head of the BC Cancer, to speak from a decision maker's point of view. We also do pre-circulate information booklet written in plain language so that participants have a bit of knowledge about the topic under discussion. The goal is to create a mini public, and I'll talk again a little bit about that later, to include marginalized groups, people that might not always have a voice or have a say in governance issues around public policy. And we want to include non-experts. So as Mike Burgess says, citizens are experts in their own lives, and that's what we want them to bring to the event. We don't want policymakers at the event because they can steer conversation in a particular direction, and it just shuts down conversations from the general public. We encourage free, equal, and respectful exchange of views and reasons for them. So people, if they say, I disagree with that, we would always ask why, so that they can have a reasoned discourse and a reasoned engagement throughout the event. Our events are explicitly not consensus-driven. It's rare to get consensus in complex societies like ours. We have to learn to live with differences. Instead, we look for points of agreement and points of contention, and we capture those. All of the events are audio recorded, so we have transcripts, and we are able to capture everything that people say. We involve key policymakers. They are involved tip to tail on these events. We have a steering committee. We consult them about their urgent and proximate policy initiatives on which they feel that public input would be of use. So we consult them throughout the process, and they are often attending the events to observe the process. So why deliberative public engagement? As mentioned earlier, not all topics are good candidate topics for public engagement. These are big events, they are expensive and resource heavy. The good candidate topics are ones that are divisive or controversial, and they're divisive and controversial because public views are split on it, or the evidence itself is controversial, and therefore consensus might not be reached. And candidate topics would be stem cell research, biobanks, and of course healthcare coverage. Also, candidate topics would involve trade-offs and outcomes of a policy decision or a policy initiative are perceived to create winners and losers. The solutions sought through deliberative public engagement, they are collectively reached. All the participants in the cohort at the deliberation, they formulate the recommendations together and they vote whether they agree with them or disagree with them collectively. They are also values-based, and I just want to say something about values-based. We all want to know what public values are. Public values are not out there like facts to be discovered. Usually people figure out what their values are in relation to conversations about a particular topic. We might all think that or feel that fairness is a value that we hold, but what it looks like, what the edges and contours of it are, usually come in a specific context, because we'd say, okay, fairness about what? What do you mean? What's the context? And that's part of the work of discussion and deliberation that goes on these events, and then us reading and analyzing the transcripts to see where those concepts and those values emerge. So the solution sought answers the question, what are the socially acceptable consequences of a given policy decision? And this is something that experts alone cannot determine. So in policy circles, the turn to public engagement over the last has been happening for the last 20 years or so, and certainly in our current political climate, it's having a bit of a day. This article was in The Economist in March of this year, talking about citizens' deliberation as a gateway to better politics. There's been a lot of talk about public deliberation and public consultation around Brexit and how divisive that is. The author of this particular article says, deliberation, quote, helps citizens engage with complexity and the trade-offs inherent in most policy dilemmas. And I put this slide up because this was a billboard campaign that started in December of 2018, billboard campaign in England, and they had an article about it in The Guardian a couple of months ago. This was a tweet by Liam Fox, who is a British politician in the Conservative Party and served as Secretary of State for International Trade and President of the Board of Trade since 2016. And I have this up here because so often public engagement is presented in the literature as a benefit to decision makers, as a way of getting informed and reasoned public input on controversial social issues. And it's positioned as a welcome alternative to often what are knee-jerk or ill-informed, top-of-mind views on what are really complex issues. And it still is that welcome alternative to those modes of collecting public input. Increasingly, however, it may also be positioned as a benefit to the public. Certainly, Brexit is a good case in point, where few people have the time or, frankly, the stomach to sift through the mountain of so-called fake news and mendacity that counts as public discourse today, such that they have a chance of understanding what is really going on. And I think we've all sort of experienced that in one way or another over the last, 3 years, 5 years. So public engagement to address complex socio-political issues, as I said, is having a bit of a day. So turning to our event on funding fair and sustainable cancer programs and services in BC. The issue on which our steering committee said that they would like public guidance was on the high cost of cancer drugs. This has been a pressing issue in cancer control for several years. Our steering committee is made up of decision makers from across Canada, from CPAC, CADIF, CAPCA, BC Cancer, Cancer Care Ontario, Saskatchewan Cancer Agency, and so forth. They all said that their biggest issue is managing their budgets, and particularly managing their drug budgets. We know that expenditures have risen faster in oncology drugs than other areas of healthcare, and there are several factors that are driving up expenditures. Factors such as prices for new cancer drugs are increasing dramatically. Systemic therapies are used in more patients. There's been a sharp rise in incident cases due to, among other things, patients living longer, and the acceleration in the number of new cancer drugs, often with higher daily drug costs and longer duration of treatment. Many of the expensive new cancer drugs have only marginal increases in health benefit and are often non-curative. So together, these factors put considerable strain on the affordability and sustainability of Canada's publicly financed provincial and territorial health systems. So the policy dilemma that decision makers are confronting is, what are the acceptable trade-offs between access to promising new treatments and programs and resource scarcity when there isn't enough money to do everything we would really like to do? So how is it that they can identify the acceptable trade-offs between scarce resources and social needs? Now, this next slide on the cancer care continuum is probably very familiar to folks. This is the one we use here at BC Cancer, and it shows the different phases of cancer control, from prevention through screening, diagnosis, treatment, coping with end of life. We have survivorship there. And we also have psychosocial and palliative care cutting across several of the phases of treatment. So this is what our steering committee said, is that that treatment bucket is taking up so much budget that they don't have a lot of extra resources to devote to the other aspects of and the other phases of cancer care. So what they wanted us to ask participants are, what are the aspects of treatment and non-treatment phases of cancer control that are important to them? And in terms of importance, what relative weight would participants give to those aspects or components of programs? And are there any conditions to those things that are important? So this next slide is how we structure our deliberative public engagements. We start off with, in this case, it was 26 demographically stratified participants, stratified to the 2016 BC Census. In advance of the first weekend, we pre-circulate a plain language information booklet to participants. We had a video that we had created for a previous project. We sent them a link to that. Then the first weekend, the first day of the first weekend is really information provision and asking questions. That's when our expert speakers come. About 3/4 of that first day is all about expert speakers and participants having a lot of time with them to ask whatever questions they want. Then after that first day, the expert speakers go away and the participants grapple with the deliberative questions themselves. So they start the deliberations at the second day of the first weekend, come up with maybe a couple of recommendations. Then they go away for a 12-day break. They go back to their homes and their families, and we encourage them to discuss the deliberation with their families, with their colleagues, with their neighbors, do any research they want to do, and then when they come back the second weekend, the first thing we do is ask them what kind of conversations they had, what kind of things came up, were they surprised? So we bring all that information back to the second weekend, and then we really roll up our sleeves and get into the heavy thought work of deliberating on the questions that we have composed for the deliberation. Participants make recommendations, they formulate the recommendations themselves, and then they vote on them. Voting is used as a tool mostly to measure the degree of support for a particular recommendation, but also if people just abstain or vote no on an agreement, we ask them why. Not to catch them out, but again, to understand reasons why people are voting the way they do and understand the limits of agreement on a particular recommendation, because that is useful to policymakers. So hopefully, we do reports, articles, online materials from this, and hopefully affect policy. So in terms of recruitment for this event, as I mentioned earlier, the goal of recruitment is to create a mini public, and a mini public is a representation of the larger public from which it is drawn. It represents the diversity of social characteristics and plurality of initial points of view in a larger society. It's ideally free from sectarian interests that can steer discussion in a particular direction and undermine civic trust. That's why we screen out experts, so that it doesn't, that kind of partisanship is hopefully not contaminating the free and equal exchange of ideas that we want to cultivate in the deliberation. We tried something new with our recruitment process for this event. We went old school. We did a mail out. We did a recruitment flyer. We mailed it out to 10,000 BC households. We engaged a direct mail marketing firm to do this, and they partner with Canada Post because we wanted to make sure of that because we wanted to make sure we had a good list, that we didn't get a lot of return mail. We sampled by BC Health Region, of which there are 5. We oversampled in northern BC. And Vancouver Island outside of Victoria, because we didn't want just the lower mainland where there's the high density population to be the only representation. We sample by health authority because people's experience with the delivery of healthcare will be different by health region. The recruitment flyer directed participants to an ARC website post page where they filled out a recruitment survey that was put in red cap. We had 220 people respond to that survey for a 2.2% response rate. The demographic characteristics in the recruitment survey we stratified by age, sex, geography, ethnicity. Chronic disease experience, that was a binary yes/no, because we did want to get individuals, members of the public who also had some experience with chronic disease, either themselves or as a caregiver, because we wanted that voice and that perspective and those experiences to inform the discussions that participants were having at the event. Parenthood, yes/no binary, stratified for income and education. The screening criteria, no financial relationship with tobacco, could not be a health advocate or policymaker. Again, those are those expert views that we wanted to screen out. And of course, they had to be available. We asked many, many times that participants be available for all 4 days, which is a sizable commitment. This is just a quick slide of BC. Sorry, you probably know what BC looks like, but you can see how big the Northern Health Authority is, that big green patch that's over 50% of the province. It accounts for only 6% of the population. So we oversampled from there, and we took sort of undersampled in Fraser and Vancouver Coastal, which is the lower mainland. So that's just to give you a sense of our health authorities across BC. So these are the characteristics of our participants. Our initial cohort was 30 people. 1 person did not show up for day 1. Another person left after the first weekend, and then 2 people left on the afternoon of the last day, all left for personal reasons. So a couple of things I want to draw your attention to in terms of the characteristics of attendees. The rurality and remote characteristics on the left-hand side. Canada Post has a way of looking at postal codes where you can assess rurality. We only had 1 that fit that criteria, but we were more interested in remote, and we defined remote location, remote residence as having to travel several hours by car or get on a plane to access cancer care. So we had just over a quarter of our participants from remote regions in BC. We were quite happy about that. You can see chronic disease. We have about a third of our participants had some experience with chronic disease, again, either themselves or as a caregiver. It was not cancer specific. 50-50 split for sex. We had a good representation for health authority. Just under half had children. Ethnicity was self-identification. It was a write-in response. And people could pick more than one ethnicity. So we've had some adds up to more than 100%. We were very pleased to get 3 Indigenous people at the event to get good ethnic representation. Age, we had good distribution there. We were very happy to get 3 from 18 to 24 age group. That's a very, very difficult age group to recruit from. And you can see the education distribution. And those are our lovely participants who worked very hard over 4 days to come up with 19 recommendations. And with that, I will hand it over to Helen.
Thank you, Colleen. I'm showing again the cancer care continuum slide. It shows the cancer journey a patient may face from their journey, from prevention all the way to treatment, survivorship, and end-of-life care. Over the 4-day event, individuals were provided with 5 deliberative questions that map directly onto the different phases of the cancer care continuum. On the first weekend, the first questions the deliberation participants were asked was what should guide policy decisions about whether to fund new cancer treatments and whether we should change funding provided for existing cancer treatments. Also on the first weekend, the second question that was asked was what should guide policy decisions about whether to fund cancer prevention programs relative to cancer treatment. Now, on the second weekend, 3 questions were asked as they became more familiar with the deliberation process. The third question that was asked was about psychosocial and palliative care treatment. We asked individuals about trade-offs between survivorship programs. And then we also asked them to consider what features we should consider in setting up an ongoing advisory panel. I should mention here that 4 out of the 5 deliberative questions were presented as decision scenarios to help them deliberate and engage with the question. And I'll give you an example of a decision scenario in the next couple of slides. Across the cancer continuum, much of the attention and resources is given to the treatment phase of cancer care. However, post-primary treatment needs to be addressed, as this phase is often neglected. Cancer and cancer treatment have a substantial impact on individuals' long-term health and quality of life. Cancer survivors are at risk for late or secondary effects, and this depends on the cancer and stage of cancer they were diagnosed with, and the therapies used to treat their cancer or reduce their side effects. Cancer survivors have supportive care needs, and this could be in a lot of different life domains, including physical, emotional, and informational needs. So the question that was posed to the participants at the event was what trade-offs should be made between different cancer survivorship programs. So this slide shows the decision scenario posed to the participants. So this slide, as well as a brief presentation on the different types of models of survivorship care given by Stuart Peacock, was used to foster deliberation amongst the participants. Participants were given information about 3 different types of programs: specialist coordinated, family practice coordinated, and individual coordinated programs, as shown in this example. The 3 different programs were described by different attributes or characteristics, which included access to treatment, whether or not individuals' physical, emotional, and practical concerns were addressed, satisfaction with the program in terms of delivery, quality, and continuity of care, and the total cost of these programs relative to the overall budget. The individuals were informed that there was a fixed number of survivors affected by the disease and were to receive the program. So this value was set at 2,000 individuals. I should also mention that individuals talked about this decision scenario in a large group format. And this was different to that of the other deliberative questions, which was done more conventionally in the small group and large group setting. The small group is a way for individuals to bring up topics of importance and to air out issues of concern, and then bring forth their topics in the large group setting to form recommendations. But due to the constraints of time and to make sure that all different phases of the cancer care continuum was discussed at the event, the survivorship scenario was only discussed in a large group format. In the large group format, the participants mostly focused their discussion on access specifically related to specialist programs and family practice programs. We let their interest drive the conversation. We didn't steer their discussion towards other characteristics of the survivorship program. Individuals also raised concerns about the individual coordinated program in that it might be difficult for a cancer survivor to navigate through the system, not knowing where to get the information. The participants also raised the issue of cost of these programs, but not in the terms of cost of the overall budget, but more in terms of the numbers of hours worked for a healthcare provider. So data generated from a deliberation event is different to that of qualitative data generated from interviews or focus groups. During the deliberative event, participants' knowledge and sense of collectivity accrue over time as they begin to learn from one another, reflect on what they've learned, and use this knowledge to help them collectively reach recommendations. Interviews and focus groups elicit different types of knowledge in that you ask the same sets of questions to different subjects. Statements made by the participants on day 1 and day 4 of the event cannot be weighted equally. People might change their mind over time in response to increased knowledge or persuasive argument, and this is viewed positively. Because the survivorship scenario was discussed on the 4th day, we can only assume that the participant is the most informed about the deliberative process. And Colleen has mentioned at the start of the presentation that the findings that we're presenting today are preliminary. We have yet to receive the whole transcript from the entire event, so we can't quite contextualize the findings from the survivorship scenario to the whole event. So 30 participants were recruited to the event, of which 26 were present on the final day for the final recommendation. In total, 19 recommendations were made across the 5 deliberative questions. Specifically for the survivorship scenario, 2 recommendations were made, and I will talk about them in the next few slides. So the first recommendation is we should implement the utilization of nurse or other health professionals for survivorship follow-up care via remote communication, teleconferencing, audio means from cancer centers. So after the deliberation, they came up with this recommendation, and the participants had the opportunity to vote on this recommendation. And all individuals were in favor. So when we looked at this recommendation a little bit further, the following themes emerged. Participants were concerned that cancer survivors may not be getting specialized care for their follow-up. They recognize that there's a need for coordinated care. Care in the community is important, and the participants were very comfortable with the idea of remote access to care. Now, the second recommendation is cancer survivors are best supported by their family practitioners. Access to family practitioners is difficult. There should be a choice to access family physicians or specialists via remote communication. When this recommendation was voted upon, all participants were in favor. And the themes that emerged from this recommendation is a concern for cancer survivors may not be getting specialized care. Care in the community is important, and cancer survivors should be given a choice about accessing their follow-up care. As you can see, there's a bit of overlap between the first and second recommendation. And in the following slides, I will present different quotes from participants at the event, and I'll give you a sense of how they came up with these recommendations. So the first theme is that participants were concerned that cancer survivors may not be getting specialized care for their follow-up. The participants of the event indicate that they preferred not to have family doctors looking after survivorship care. They raised concerns that family physicians may not have sufficient training in oncology, and this is highlighted by this quotation. Some people will feel uncomfortable of their family doctor and the knowledge that they have, right? The participants discussed that there is a need for physicians with a subspecialty in oncology, especially in smaller and more remote communities in the province. In our sampling approach, we sampled participants based on their experience with chronic conditions, either themselves or as a caregiver. So that enables the participants to talk freely about their personal experience with their healthcare provider. And one participant made a reference to the patient speaker from the first day of the event and the speaker's challenges with his prostate cancer diagnosis. So my concern about the family practice arrangement while it seems to check a lot of boxes, is inconsistency. The challenge for cancer survivors to access specialized care was also brought to light by participants living in more remote parts of the province. The quotation here is from a woman living in the interior of BC in a very small community of 1,500 people and about the doctor shortage. If you're in a rural community that's already having a doctor shortage, you're already in a disadvantaged situation. So the people that are going to fall through the cracks without any umbrella services at all will be the ones in the remote communities. The next theme is the need for coordinated survivorship care. Participants discuss the challenges cancer survivors face when navigating through the healthcare system and how to access appropriate and reliable information. They stress the need for a specialist practitioner of some sort with this oncology knowledge, but this practitioner does not necessarily need to be a clinician. People don't know where to access information. Isn't there a central coordinator of each community, like a nurse that isn't getting paid as much as a practitioner? There's still somebody that can kind of direct a person in the right direction. In addition, participants wanted survivors to have a coordinator similar to that of a caseworker who knew the specifics and details of their file and had the knowledge of cancer. This way, this person would be able to triage the cancer survivor to receive the appropriate service. The problem is that you don't actually have somebody that is informed about your case. If you want to engage other healthcare professionals, you're going to get the best bang for your buck is our caseworkers that can pull your file and go through it. They also recognize the challenge of having access to electronic records, as shown on the bottom quote here. One of the challenges that I see is access to health records, that a lot of your records is now sitting with that specialist, and so for follow-up, sometimes it's related to the primary health care program. Comfort with remote access and survivorship care. Throughout the entire discussion, the participants were very open to remote communication for care. Some of these individuals had direct experience with their family members. They perceived it to be more convenient for individuals than sitting in the waiting room and wasting time and not even seeing their doctors. And they also feel that remote communication could reduce the workload of family physicians and therefore be more efficient in terms of time and resources used. Teleconference is the way to go, not just rural communities. I think it should be everywhere. I can go in and sit for 2.5 hours with an appointment and not see my doctor. So I do see that as being a recommendation for taking some of the workload off of the physicians and allowing them to do it in a better time frame. The participants preferred that the remote communication be coordinated through the Cancer Center to ensure that it was being conducted by a specialist with the right level of experience. Every hospital has a consulting room that they could talk to someone at BC Cancer. Something like that to make it easy to take away from the burden of going to the Cancer Center, getting that level of care at the Cancer Center without physically being at the Cancer Center. This quotation highlights a lot of different points: ease of access, specialized care, and also the emotional burden survivors may experience having to return back to a cancer center to receive care. The last theme related to the recommendations is about choice. Survivors should be given a choice about how to access their follow-up care. You should be able to choose, because what I would want is the option too. If I don't want to go to the family practitioner, to then use someone else via telemedicine. This quotation is nice because the choice is clear. She wants choice, and choice should not be dependent on where this person lives in the province. So this slide here shows the two recommendations again. The first one, the participants formulated was we should implement the utilization of nurse or other health professionals for survivorship follow-up care via remote communication, teleconferencing, audio meets from the cancer center. The second one is that cancer survivors are best supported by family practitioners. Access to family practitioners is difficult. There should be a choice to access family physicians or specialists via remote communication. So I hope that the quotations presented earlier shows you how the participants came up with these recommendations. The key points that were raised were the need for specialized care and the coordination of this care. They prefer to have specialists with oncology training. It didn't matter if it was a clinician, but also just someone that had this level of training. Another point that was clear from the discussion was that people displayed a very high level of comfort with remote communication in accessing this care. And remote communication to them meant teleconferencing or audio means. And choice. Choice is a very big thing in accessing the care, and choice is not dependent on where the individual lives. So they could be from a remote area or living in a major center. There were two other themes that were not captured in the recommendations that we want to highlight today. One is that remote survivorship care needs to be ongoing. This quotation talks about his direct experience with telehealth with his dad undergoing cancer. We had our first teleconference when my dad was first diagnosed with his cancer, and it was a great experience because we were able to talk to the oncologist, but it only happened once through the whole process. It would have been nice to have it continuously so we can get the information and we're able to ask questions. He recognized that the teleconferencing, remote access to health was very important, but to make it beneficial, it has to be ongoing. And the final topic that was discussed was the transition of cancer from being perceived as an acute disease to being able to be managing it over time. Currently, the way the healthcare structure or infrastructure is set up, it is set up to manage acute disease in specialized centers. If we're thinking of changing that model, it has to be more diffused into the community. So this individual recognized that services needs to be out in the community for survivors to access. And the last quotation here is from a gentleman with experience in the Healthy Heart program, and he thought that it could be used as a model for survivorship care. I know in the heart area where I've had health issues, there's a Healthy Heart program. If I'm needing some guidance, I go to that lady nurse, and she gets me going in the right direction. And I don't know if that's available for cancer survivors or not, but it would be helpful if it was there. So today, Colleen and I presented public's preferences for cancer survivorship program from the perspective of the general public in BC. So in summary, the participants at the Deliberation events raised several points, one of which was concern that survivors may not be getting specialized care. Their preference was for them to access health practitioners with oncology training. During the discussion, the participants indicated a high level of comfort with remote access to survivorship care and communication, especially if it's coordinated through cancer centers. Survivors should be given a choice of whether they want to follow up with their local family physician or with a specialist via remote communication. And this choice should be given to all survivors. The participants recognize the need for coordinated care, and care in the local community is important. And finally, the participants supported that there seems to be a paradigm shift for treating cancer as a longer-term health condition. So I'd like to acknowledge the research team, the PI Stuart Peacock and Mike Burgess, as well as Sarah Costa, the facilitation team, as well as funding from CIHR. And I thank you for your attention, and we're happy to take any questions.